Hi, everybody. I'm Dr. Hussein AlGahtani. I'm a consultant neurologist in National Guard Hospital in Jeddah. I'm very delighted to be with you, and hopefully you'll spend a good 15 to 20 minutes with me and enjoy the presentation. The title of the presentation is Fingolimod, Important Messages to Remember. This is my disclosure. I start with a case presentation of a 40-year-old man who was previously healthy except for diabetes mellitus, and then 3 months earlier developed a left foot drop which recovered over 5 weeks. Shortly after, he began to experience tingling below the knees, bilaterally extending up onto the back. So these are indicating either brain lesions or spinal cord lesion. The brain MRI showed 3 white matter lesions, each approximately 1 centimeter in diameter, one of which enhanced after gadolinium administration. His symptoms resolved after 2 weeks. Neurological examination 1 month later was normal except for minimal weakness of the right hamstring and slight diminution of vibration sense in toes. An appointment was scheduled to discuss the use of disease-modifying therapy, but unfortunately, the patient developed another episode or attack with vertigo, vomiting, blurred vision, and unsteady gait. At that time, his examination showed bilateral internuclear ophthalmoplegia, and as you can see, that with I&O, there is limitation of AD duction in one eye, with the presence of nystagmus of the abducting eye. So the diagnosis was clinically definite multiple sclerosis with new attack, and he received a 5 days course of methylprednisolone therapy, 1,000 milligram daily, intravenously, and he came back after finishing the steroid course to start disease-modifying therapy, which he elected to use oral therapy. This is the choice of the patient. He said, I don't want any injectables, I don't want intravenous solutions, I would like to go for oral therapy. And since he's a male patient with the right diagnosis of relapsing remitting MS, we thought that Gilenya could be, or Fingolimod or Figona, whatever available in the hospital at that time. We thought that Fingolimod is the best choice. At that time, when he visited us, he had only very minimal left eye NO remained. So he recovered even with his brainstem attack, he recovered partially. So with this case, we'll go into the mechanism of action of Fingolimod. It's known that it works on sphingosine 1-phosphate receptors, and it's an agonist binding to 4 out of the 5 type of receptors or subtypes of receptors. And so it's working as a functional antagonist. So this molecule works by altering lymphocyte migration, thereby sequestering all lymphocytes in the lymph nodes and spleen, and preventing lymphocytes from going into the brain and exerting its bad effects. So this is the sequestering effect of Fingolimod, as you can see, trapping in the lymph nodes and spleen. Nodal trapping will make the lymphocytes unavailable to enter to the CNS and will stop initiating the MS pathology. In addition to its immunomodulatory effects by blocking the lymphocyte egress from the lymph node, it has also potential effect on blood-brain barrier, which promote adherent junction assembly and decrease permeability of the blood-brain barrier. And there is a potential CNS effect with neuroprotective effect and increased remyelination. These are the different receptors. It's available. The S1P receptors are available in the eye, available in the heart, available in the kidneys, and that's why some of the side effects of this medication occur because of these widely distributed receptors. The efficacy of Fingolimod is well known, studied, studies. It reduced the annualized relapse rate by around 55% as compared to interferon beta-1 intramuscular injection. and it has a reduction on the disease progression by 30% compared to placebo. In a subgroup analysis, it's highly active in patients with high-latent disease. Despite interferon therapy, there is huge impact of Fingolimod on the annualized relapse rate by around 61%, and the reduction in the lesion count and brain volume. These are the two major studies, the Freedoms 1 and Freedoms 2 and Transforms studies. There is a lot of real-world experience studies, and it showed similar efficacy as the original studies. The time to benefit, MRI is used as a surrogate measure of efficacy, and the MRI was done in the Freedoms and Freedom 2 studies at baseline, 6 months, 12 months, and 24 months later. And based on the analysis, the effect of Fingolimod start around 6 months from the onset of taking the medication. This includes reduction in gadolinium load and also brain volume. The key monitoring for adverse effect, number one is pregnancy test in women, ECG prior to starting Fingolimod, and if it's abnormal, cardiologist should see the patient. CBC and liver function test after the first visit and the follow-up 3 months later, and ophthalmological examination 3 to 4 months after starting Fingolimod, looking for macular edema. The side effects are divided into common, such as headache, influenza-like features, diarrhea, back pain, elevated liver enzymes, and cough, and less common, including serious infections, cardiac arrhythmias, and macular edema. Recent data from the International Fingolimod Pregnancy Registry showed significant congenital malformation in patients taking Fingolimod while becoming pregnant. So it is advisable to stop Fingolimod at least 2 to 3 months before attempting to get pregnant. In addition, PML was reported in around 40 out of 300,000 cases distributed in the world, and almost all Fingolimod-associated PML cases occur after more than 2 years of therapy at the age of 50 and above. So if the patient is 50 years or older and have been on Fingolimod for more than 2 years, you have to be cautious about the complication of PML. Washout period, it's well known that you need a washout period. If the patient is using Tysabri, you have to wait for at least 2 to 3 months. If the patient is using beta interferon or glatiramer acetate, there is no need for washout period. A patient will, after teriflunomide, it's not well known. However, you can use the rapid elimination technique for teriflunomide. If not used, washout period should not be shorter than 3.5 months after stopping teriflunomide. Dimethyl fumarate, there is no studies done. However, you have to watch WBC count and make sure that they become normal before you start Fingolimod. Switching from Fingolimod to alemtuzumab, it's not recommended. The average washout period is around 2.7 months. However, switching from alemtuzumab to Fingolimod is not recommended. This is another case of a 32-year-old woman with multiple sclerosis presented to the general practitioner with 5 days history of numbness, weakness in right leg. She felt well in herself and did not describe any symptom to suggest an intercurrent infection. She had been taking weekly intramuscular injection of interferon beta 1A for the previous year and a half, and reported side effects such as flu-like symptoms, myalgias, and these may last up to a day or two. She asked if there was a need to change her treatment and what alternatives were available. In this patient, Fingolimod is an option. These are the drugs. Now we have more than 17 medications approved by the FDA. And as you can see, started in the 1990s with interferon therapy and glatiramer acetate. And then the injectables came, and then oral therapy came, and now we are in the era of also biological therapy. What are the factors influencing disease-modifying therapy choice? It depends on the disease factors, such as the disease course, activity, relapse rate, the MRI finding, and the severity of relapses. Patient factors, such as patient preference in our second case, desire for pregnancy, comorbidities, burden of monitoring and drug tolerability, and healthcare system related, such as the cost, availability, licensing, etc. As you can see here, Fingolimod is in the middle range between the efficacy and the safety. It's better than interferon therapy regarding efficacy, but less effective than alemtuzumab. And it is actually less safe than interferon and more safe than alemtuzumab. Treatment of multiple sclerosis might be divided into clinical isolated syndrome and relapsing MS. The best choice, the first option is Fingolimod or Tecfidera. If not, then we can use Copaxone, interferon therapy, and then others, you can use other disease-modifying therapy. If the patient have clinical isolated syndrome, Fingolimod comes as a second option as compared to Ocrevus or natalizumab. And active disease, you might go for Ocrevus, etc. So these are choices based on the experience, the preference, and availability of medication. This is the Minactrum's algorithm for MS treatment. As you can see, it is based on aggressiveness of the disease. Non-aggressive therapy versus aggressive therapy. Fingolimod is considered one of those medication used for aggressive relapsing remitting multiple sclerosis. How cost-effective are disease-modifying therapy? As you know that more than half of the direct medical costs in people with multiple sclerosis are related to disease-modifying treatment, and there is a wide variation in the cost between different countries. However, the cost is around $70,000 per year, and several studies have found that disease-modifying therapy are not cost-effective at accepted economic threshold. How can we improve the cost effectiveness? By, number one, lowering the drug pricing by drug companies, make generic drugs available, use some of the medication as an off-label prescription, and increasing use of disease-modifying therapy that do not require ongoing maintenance, treatment, or monitoring. These are some of the options to reduce the cost. As you know, there are some important definitions for every neurologist to remember. Innovator drugs or brand drugs these are approved brand medicinal products. It's known as also as the reference products, and these are the products where the initial FDA and EMA approval came through. And there is generic, which are copy of the brand name drug with the same safety, strength, route of administration, quality, performance characteristic, and intended use. Figona, as you know, is one of the generics used to substitute Fingolimod in Saudi Arabia. It's available now in the Ministry of Health, and there is a patient registry. More than 1,000 patients are currently using Figona. And in my practice, I have more than 150 cases. So far, I couldn't find any difference between the generic and the brand drugs regarding the effectiveness and side effect profile. The patient registry now include different hospitals, including National Guard, Ministry of Health, and also now military hospitals are joining also smoothly. There are also some private hospitals using Figona with no problems. The cost is huge difference, 2,100 Saudi Riyal for Figona as compared to the brand name 6,000 Riyal. And I have heard just recently that the price is even less, to 1,650 instead of 2,100 Riyal. So, in conclusion, and to be on time, Fingolimod is a suitable first or second line disease modifying therapy for individuals without cardiovascular risk factors who desire once daily oral therapy and have a high likelihood of adherence with required monitoring. And it had been approved in 2018 to be used in children aged 10 years or older. Generic drugs is not required to be identical to the reference drug, but should be comparable or highly similar within a pre-specified range with no clinically meaningful differences in safety, purity, and potency. Success in development of generic drug depends on ability to offer a similar, safe, and effective product at a cost-saving. Too relaxed requirement may jeopardize efficacy or patient safety, and too stringent requirement create a disincentive to pharmaceutical companies. Generics might be cost-effective and help patients, especially if they are in the private sectors. And as you know, Saudi Arabia now in 2030 are looking for cost effectiveness and to save the general public money. So maybe generics might have some place in 2030 medical expenditure. This is a study I published in 2020 about Fingolimod relapsing remitting multiple sclerosis. More than 100 cases have been studied, and the results or conclusions show that the Fingolimod work with reduction in clinical and radiological of disease activity. We should have hope, and in 1990s, when I started my residency in Canada, we used to have no medication as disease-modifying therapy. Now we have 17 drugs which are highly effective. And what I'm telling my patient that we used in the past, the disease used to control us and control the patient. Now we have the upper hand to control the disease activity and make the patient having a normal life. We are looking forward for a cure for MS, and I'm sure it is coming soon. Thank you very much for your time. I'm looking for any questions or queries.